Hello all, welcome back. So as promised, we are starting with the Emree series. We have covered dermatology part 1. It was uploaded way back. You can go and watch that if you haven't. And in the coming days, we'll be covering all the topics that are related to Emree. Will be covering it syllabus wise. I'll give you an overall view of how we are going to do the syllabus. Maybe today or tomorrow, so that you have an idea what you can expect for the 1 month to come before the exam, before the actual cycle begins. But you may, actually select a date even beyond December. So let's get started. So last time we had talked until psoriasis. We haven't talked about psoriasis. So psoriasis, it is a very intensely itching and scaling disorder. So what happens is we have a stratum basale, which is involving all the stem cells of the epidermis. So from there, the newer cells come and it goes to the topper layers and finally it is shed off. So there is a turnover rate. In psoriasis, what happens is this turnover becomes so rapid that there is intense scaling. Okay, because of the hyperproliferation of dermis, there is intense scaling and also there is inflammation in dermis. So it's a combination of hyperproliferation of epidermis with inflammation in dermis along with systemic manifestations. You can have varied manifestations of psoriasis. There are different types of psoriasis as well, and you can have systemic manifestations. So usually in the stem of the question, you usually have scaling, intense scaling, especially the classical psoriasis you have in the extensor aspect of the forearm and arm, and you also have characteristic nail findings, that is nail pitting. Okay, so this is the stem they usually give, so you can identify that it is psoriasis. So psoriasis vulgaris or plaque psoriasis. Vulgaris, whenever you hear the term vulgaris, it means a common type. Okay, acne vulgaris means the common type of acne. So psoriasis vulgaris means a common type of psoriasis. It is classically having the silvery white scales. That is the description of the scaling in psoriasis, and it's usually in the extensor aspect of the body. And there is something called Auspitz sign. So what is Auspitz sign is that you scrape off the scales and finally you will see bleeding points, just like you see in this picture. You will see bleeding points, and that is called Auspitz sign. We have talked about Koebner phenomena as well. That means whenever there is a trauma, newer lesions will appear on the site of trauma in case of psoriasis and other disorders which we have discussed in terms of Koebner phenomena. So that is Koebner phenomena, which means where if you scratch an area or if there is a trauma, newer lesions will appear on the site of trauma. Pseudokoebner means it is due to actual inoculation by the infective, maybe viral thing. Okay, like in case of molluscum contagiosum, you can have pseudokoebner. This is Koebner phenomenon, and the changes in nail is pitting of nails and onycholysis. So that was psoriasis vulgaris. You have seen Koebner phenomena. Koebner phenomena is mainly seen in vitiligo. You can see it in psoriasis. Okay, pseudokoebner you can see in molluscum contagiosum and HPV infections. These are the types of psoriasis, like gutty psoriasis, where you have raindrop lesions. Okay, and pustula psoriasis, where there is pustules. Pustules means there is pus-filled lesions on the skin. And it is mainly seen with sudden withdrawal of systemic steroids. Then erythroderma. Erythroderma is not like a variant of psoriasis. It is just that one of the diseases, major dermatological condition which is predisposing to erythroderma is psoriasis. Other than eczema, you have psoriasis which is leading to erythroderma. What does erythroderma means? It is extensive lesions all throughout the body which is involving more than 90% of the body surface area. Okay, that is called erythroderma. It is an exfoliative dermatitis. And one of the conditions predisposing to erythroderma is, so erythroderma is like a condition, any condition of the skin, which involves 90% of the body surface area. The exfoliative dermatitis involving more than 90% of the body surface area. One of the conditions is psoriasis, another can be eczema. Psoriatic arthritis is another variant, which is a seronegative spondyloarthropathy, HLA-B27 positive, and it usually involves the DIP joint. You might also have heard about inverse psoriasis, which means usually the psoriasis affects the extensor aspect. In inverse psoriasis, it involves the flexor aspect. So these are like the types of different psoriasis. So we have talked about erythroderma. We'll also talk about some conditions which involve, percentage of body surface area, and according to that, we'll name it. So one is Stevens-Johnson syndrome. The other is toxic epidermal necrolysis, and a more similar condition is staphylococcal scalded skin syndrome. So Stevens-Johnson syndrome can be due to any drug. Okay, it can be a drug reaction. Some of the culprits, allopurinol, valproate, carbamazepine. There are so many drugs which can predispose to Stevens-Johnson syndrome. What is the difference between Stevens-Johnson and TEN is the percentage of body surface area that's involved. If it's less than 20% of body surface area, it's called Stevens-Johnson syndrome. If it involves more than 30%, it is called TEN. In between that, it is SJS-TEN overlap. Just like you can see in this image, less than 10%, more than 30%. More than 30% is toxic epidermal necrolysis. These are all drug reactions, usually drug reactions. What is staphylococcal scalded skin syndrome? That is SSSS. That is a super antigen of the Staphylococcus aureus. It can lead to extensive lesions all throughout the body. And it's a toxin mediated. It's an exotoxin, and the characteristic rash is called sandpaper rash, but it spares mucosa. In TEN, it may involve the mucosa, but usually SSS spares the mucosa. So that was discussed because we have discussed about erythroderma. Erythroderma is more than 90% of the body surface area. SJS is less than 10%. TEN is more than 30%. And SSSS, staphylococcal scalded skin syndrome, is due to staphylococcal superantigen and hexotoxin. So it is toxin mediated. I'll come to treatment of psoriasis. So the first treatment comes about topicals. You can give emollients and coal tar to actually, to moisturize the area. You can use salicylic acid, you can use topical corticosteroids, calcipotriol, which is topical vitamin D, and tazarotene or acitretin, which is topical vitamin A. Then the next step in treatment is phototherapy. If all that fails, you can go to systemic therapy, wherein you use methotrexate or steroid-sparing agents like cyclosporin. The final ones are biologicals, which is TNF-alpha inhibitors like infliximab, adalimumab, and etanercept. Systemic corticosteroids are usually avoided because they have a risk of severe withdrawal flare. Just like we have discussed, when you suddenly stop systemic steroids, there is going to be an extensive flare of lesions. So usually you avoid oral steroids. So your treatment can be topical emollients like topical vitamin A, vitamin D, salicylic acid, and phototherapy, and systemic therapy involving methotrexate, cyclosporin, and biologicals like TNF-alpha inhibitors. And classify based on the percentage of involvement. Less than 3% is mild, 3 to 10% is moderate, more than 10% of body surface area is severe. So that was regarding the management of psoriasis. Usually the questions come from, you identifying that as psoriasis, then you have to treat, the treatment options will be asked. It's like a step-up treatment. Okay, now coming to lichen planus. Lichen planus, we classically say it as 6 Ps, that it is purplish, it is pruritic, polygonal, plain topped, or papules or plaques. So these are the different morphologies that you can see. It can be plain topped or papules or plague. We've discussed about the morphology of lesions in the first part. You can go back and see what is a macule, what is a papule, what is a plague. Okay, so this is the characteristic description of lichen planus. It's purplish. Usually in this time of the question they mention purplish, pruritic, and maybe plague or papule. Okay, then you have to think about lichen planus. There's something called Wickham striae, that is the net-like or lacy white appearance of the lesion, that is called Wickham striae. Again, it's in the flexor distribution, unlike psoriasis. Psoriasis mainly in the common psoriasis or psoriasis vulgaris was in the extensor distribution, and lichen planus can also have oral lesions. Okay, so that is lichen planus. Usually you will be asked to just diagnose it as lichen planus. Coming to pityriasis rosea. Pityriasis rosea is caused by HHV7, human herpes virus 7. Usually it has a herald patch. So that is like the description of pityriasis rosea. So they may not actually describe it as herald patch. They'll say that initially there was a patch and then it finally spreads to the back, like in the Christmas tree pattern, or collarette of scales. So that is herald patch with collarette of scale. Herald patch means the initial patch, the first one, which is, giving a hint that it is going to spread, and that is pityriasis rosea. Another similar sounding, pityriasis versicolor, and the etiology is different. This is caused by a fungus, Malassezia furfur, and it is scaly lesions of different color. It is from the name itself, it's versicolor, means variety of colors. So it can be hyperpigmented, or any other color. So for the diagnosis, you can use KOH mount, because since it's a fungi, you can identify the hyphae in the KOH mount under microscope. And the treatment of choice is fluconazole. So those were the scaly lesions we have discussed in the previous part, the vitiligo and depigmented lesions. We have discussed about pityriasis versicolor and pityriasis rosea. So now we'll come to skin infections. Now this part is really important because you have to be very careful how to identify a skin infection as a superficial infection, a bacterial etiology, or a deeper infection of multiple etiology. You have to differentiate that. For that, in the question, they'll describe the lesion or the involvement, and then you have to make out. So in the skin, you have epidermis, dermis. In the dermis, you have so many appendages like hair follicles. The sebaceous gland also will be always associated with the hair follicle. Okay, this is a sebaceous gland. Then you will have eccrine and apocrine sweat glands. Then there is a subcutaneous tissue below the dermis, and below that there is a fascia which is separating it from the muscle layer. And deeper you have the bone. This is the layer. So when you talk about the kind of infections that involve the different skin layers, so here we'll just see the terminology. We'll discuss that as we go along. So folliculitis means infection involving the hair follicle. Again, that can spread to more than one, to involve a pharyngeal or a carbuncle. Impetigo is a superficial bacterial infection of the skin. Erysipelas is a very, demarcated lesion. So erysipelas, the main, word is demarcated, highly demarcated, maybe involving the face and all. Okay, and it involves the dermis. Cellulitis is like a spreading infection. It can start from the dermis, go up and down to involve the subcutaneous tissue as well as the upper dermis and epidermis. Necrotizing fasciitis, again a deeper infection. It's polymicrobial, mainly involved by um, the anaerobic and gram-negative organisms, and it requires extensive treatment. Maybe you have to extensively debride in terms of necrotizing fasciitis to prevent the spread of the infection. Now we'll come to each one by one. So impetigo, as I mentioned, it's a bacterial infection of the epidermis, superficial infection, usually in children. There are two types, bullous and non-bullous. Non-bullous is caused both by strep as well as staph, because usually the skin infections are caused by major two bacteria, which is streptococcus and staphylococcus. So non-bullous caused by both. And the classic description of the lesion is golden brown, honey colored crust. So usually in the question I mentioned, in a child there is a lesion over the face and it is having a honey colored crust. So then you have to think about impetigo. It can be in the perinasal or perioral area. Just like I mentioned, there is bullous and non-bullous. Bullous impetigo is mainly by staphylococcus. Non-bullous is both by staph and strep, and bullous is by staphylococcus. This non-bullous is the honey-colored crust. The treatment of choice is topical fusidic acid or mupirocin. Topical treatment would be enough in the mild or non-severe cases. Otherwise, you may have to go for systemic, but usually it is topical. Now, erysipelas. Erysipelas is caused by group A streptococcus. So mainly the bacteria involving the skin are strep and staph. Group A streptococci cause erysipelas. It involves upper half of dermis along with the lymphatics. The classic feature that differentiates erysipelas from other infection is that the margin is well demarcated and raised. So here you can see it is very well demarcated and it is raised over the skin. It's very, very reddish, right? Erythematous, and that is called erysipelas. Then there is cellulitis. Cellulitis is by both group A streptococci and Staph aureus. It also involves a subcutaneous tissue. So it can start from the dermis, go up or down, and can spread. So the margin is usually ill-defined. Okay. In erysipelas, it was well-defined, and here in cellulitis, it is ill-defined. So maybe a diabetic patient coming with redness and raised temperature over the lower limb. Usually, you can think about cellulitis. Next is necrotizing fasciitis. It is polymicrobial caused by multiple organisms and it's a deeper infection followed by pain, anesthesia and necrosis because it involves all the nerves, it involves the vessels, so there is necrosis. Okay, just like in the terminology, this necrotizing fasciitis. Fasciitis means it's involving the fascia, so it can go deeper into the muscle and bone. It can go up and involve the dermis, epidermis, and it can be severely necrotizing. You have to debride. There is no other treatment. You have to surgically debride and then give antibiotics. Okay. So then we'll come to the infection of hair follicle. If it is involving one hair follicle, it's called folliculitis. If it's involving hair follicle along with the perifollicular area, it's called a furuncle. And if it's involving multiple hair follicles along with the adjacent area where there is like a coalesced lesion, there is a raised lesion with pustule, it is called a carbuncle. Okay, it will have a dot here because it is involving the hair follicle. It will have a black dot, or you can see a pinpoint there, pus point there. That's called folliculitis. If it's involving perifollicular area, called furuncle. If it's involving more broader area with multiple hair follicles and adjacent area involved, are called a carbuncle. Okay, now we'll discuss a question. A 28-year-old woman present with sudden hair loss over the scalp. So it is about hair loss. Hair loss can be alopecia. Hair loss means alopecia. It can be a scarring alopecia or non-scarring alopecia. So from the question, we'll see if it is a scarring alopecia or a non-scarring alopecia because the etiology is different for both. On examination, you observe a well-demarcated, smooth, round patch of complete hair loss on the parietal region. no erythema or scaling. Nail pitting is also noted. What is most likely diagnosis? So that means uh, it is a non-scarring alopecia, but there is nail pitting. That is another feature which they have mentioned along with this. Okay, so we'll see the options. Tinea capitis, usually there will be scaling, right? Because it's a fungal infection, there can be scaling. So it's a scarring like alopecia. It can be non-scarring also, but when you just hear tinea capitis, it can be extensive scaling with you know, uh, and scarring. Telogen effluvium and anagen effluvium, that is also loss of hair in different stages of the hair growth. We'll discuss that in a while. What is alopecia areata? Alopecia areata is an autoimmune disorder which involves loss of hair. It's usually like a patchy hair loss, along with nail pitting. Okay, so here the catch is nail pitting along with the non-scarring alopecia involving one particular area, one patch area. So that is alopecia areata. And it's a 28-year-old woman. It's autoimmune disorders you can see in women, mostly women, right? What is trichotillomania? Trichotillomania is a psychiatric disorder wherein the person actually plucks his or her own hair, and usually it's from the accessible area, so maybe on the frontal area, on the parietal area. And usually what happens is there is different growth of hair. You can't actually see a complete patch being lost. They'll pluck and again the hair will come. So different length of hair will be found in that patch area. So that's called trichotillomania. So here the answer is alopecia areata. Why? Because it's a non-scarring alopecia along with nail pitting. So it's non-scarring alopecia with autoimmune hair loss presenting with well circumscribed patches of hair loss. So there are patchy hair loss. Skin appears smooth, normal with no scaling, no inflammation, no scarring. Nail pitting may be seen. That was the key in this question as well. And exclamation mark hairs may be seen, like small hairs which is coming out. That is called exclamation mark hair. Okay, other options, tinea capitis, usually with scaling. But here there was no scaling and broken hairs. Telogen effluvium means diffuse hair shedding without discrete patches. So it's telogen effluvium and anagen effluvium is hair loss at different stages of hair growth. So if it's a complete hair loss without actually patchy loss, it's called telogen effluvium. Trichotillomania, as I mentioned, it's a psychiatric condition wherein the patient actually plucks his or her own hair. So usually the hair loss is irregular with broken hairs at different lengths, usually in accessible areas because they are plucking their own hair. So that was the question regarding alopecia areata. Now we'll come to dermatophytosis. Dermatophytosis are superficial infections of the skin caused by fungi. Okay, and it based on where it is involving. If it's involving the head, it's called tinea capitis. If it is involving the body, it's called tinea corporis. If it's involving the crura, the intercrural areas in the groin area, it's called tinea crurus. So that is based on where it is distributed. Among tinea capitis itself, there are different terminology, like there can be a gray patch, like hair loss with broken off hairs. Since the species is different, the manifestation is also different. And there is black dot, that is brittle hair sharp flakes at level of the scalp by tinea verrucosum and tinea mendicrophytes. Then there is chirion, which is inflamed, indurated and boggy swelling, and it's by tinea tonsurens. And there is favus. Favus means the description is yellow cup-shaped crust, okay, composed of mycelia and epithelial debris. It's by tinea schonleni. So mainly, otherwise you can also classify that into ectotrix and endotrix, something which is penetrating into the hair or something which is superficially affecting, ectotrix and endotrix. Otherwise you can, based on the appearance and the morphology and the distribution over the scalp, you can classify that into black dot, Kerion, and Favus. Favus is like a more extensive and like yellow cup of scutellum. Okay, Kerion is like a body swelling, and black dot is when the hair shaft is brittle and it breaks. And the treatment of choice is griseofulvin. Now this is a hair perforation test for dermatophytes. Just like I mentioned, you have ectothrix and endothrix. So here in mentacrophytes, this hair perforation test is positive. It goes in, right? It perforates in. Okay, that is called hair perforation test positive, shown by Taenia mentacrophytes. But hair perforation test is negative in case of Taenia rubrum. Okay, that is one thing that you identify to differentiate between ectothrix and endothrix. So that was regarding Taenia capitis. Okay, you have Taenia corporis, Taenia cruris. Mainly the treatment is going to be antifungal. And you have to, you might also have classified that into 3 different organisms, right? That is trichophyton, microsporum, and epidermophyton. Wherever phyton is there, you will have nail involvement. So trichophyton and epidermophyton will have nail involvement, and microsporum do not have nail involvement, so it involves only the skin and hair. Trichophyton, it is tri, means all 3, that is skin, hair, and nail. So that is the difference between trichophyton, microsporum, and epidermophyton. So that is the different species that is causing dermatophytosis. So mainly in dermatophytosis, you know, based on distribution, you have Taenia capitis, cruris, and corporis. Based on the species, it is microsporum, trichophyton, and epidermophyton. Based on whether it's penetrating the hair or not, it's ectothrix and endothrix. So there are different kind of classification. You have to know that the treatment is going to be antifungal. Coming to orolabial herpes. So it's caused by herpes virus. Human herpes virus 1, which is called human herpes simplex virus 1, HSV1. So usually above the waist we say it is caused by HSV1, but it's not a very strict rule. HSV1 can cause even below the waist, like genital lesions, but HSV2 can cause above the waist as well. But usually the general rule is HSV1 goes above the waist, which means there is orolabial herpes, and genital herpes is caused by HSV2. It's also called cold sore. The treatment is antiviral acyclovir 400 mg TID for 5 days. Now another viral infection, again from the herpes group of virus, that is caused by varicella, that is chicken pox. So HHV1 and HHV2 are HSV1 and HSV2, which is human herpes virus 1, and human herpes virus 2, which is herpes simplex virus 1 and herpes simplex virus 2. HHV3 is varicella zoster virus. So that is causing chicken pox, and the distribution is usually centripetal. It's usually start from the trunk and then spreads outwards, and there are pleomorphic lesions. Now this is characteristic of chickenpox. Pleomorphic means different morphology existing together. So there are some lesions which are crusted, some lesions which are like vesicles. Usually it is a dewdrop on rose petal appearance. That is a classic lesion, which is a vesicle, a fluid-filled vesicle. But it can have pleomorphic lesions wherein some of the lesions have already started crusting. And the infected period is some around 4 days before the rash start appearing, until all of that is crusted out. Okay, until all the lesions crust. And usually the treatment mainly is supportive management. You may give acyclovir as soon as you diagnose chickenpox, and you have to isolate the patient because it's highly infective. Then there is herpes zoster. Herpes zoster is actually the reactivation of varicella zoster virus, because varicella zoster virus has a predilection and a predisposition to infect and stay dormant in the dorsal root ganglion. So sometimes after, when the patient becomes immunosuppressed, it can reactivate, and it leads to highly painful lesions which are like crusted and painful, lesions which are like grouped vesicles on red base, and it's dermatomal in distribution. Now this is the key here in herpes zoster. So in every dermatological condition you have to keep one key clue so as to diagnose it. Okay, so it is unilateral because it's dermatomal, because it is staying dominant in the dorsal root ganglion, spreading, it's only spreading in the dermatomal distribution. You may see it on the face, on the ophthalmic branch of the trigeminal nerve. Okay, so it's unilateral, dermatomal in distribution, and it's highly painful. And after that, you have a neuralgia, which is called post-herpetic neuralgia, and that can be prevented by giving the patient acyclovir, and the dosage is 800 mg 5 times daily for at least 7 days. So this is the treatment. This is how you identify herpes zoster. Another viral infection, it's molluscum contagiosum. It's a type of pox virus, okay, molluscum contagiosum virus. And the classic feature is central umbilication. Pearly white papules with central umbilication. This is what you call as a central umbilication. And it shows pseudocopner phenomena. So you have known Kopner phenomena. Kopner phenomena is appearance of similar morphological lesions on the site of trauma in case of psoriasis and vitiligo. But pseudocopner means it's not due to trauma. It's not, it's not due to an immunological phenomenon, it's rather an infective phenomena, like in molluscum contagiosum and herpes, where there is a trauma or or you scratch a newer area, there is spread of lesions. That is called pseudocopner phenomenon. It's usually self-limiting, can be seen in children also. In immunocompromised, it can be highly widespread, and that needs treatment. Next is warts. Warts is caused by papilloma virus, okay, HPV virus. And the common warts is called verruca vulgaris. Vulgaris, I've told you, the term itself means common. So common type of wart is called verruca vulgaris. And topical treatment for warts is salicylic acid. You're trying to, make it softer, and try to because it is highly thick and crusted, you're trying to make it soft using salicylic acid. You may also use podophyllitoxin, especially for genital warts. Otherwise, if it's resistant, you can go for electrocautery or cryotherapy. Another common viral infection in children with lesions all over the body, especially perioral. It can include palms and soles. So that is one characteristic finding here. It involves the palms and soles. It's a vesicular rash, okay, usually in children. And there are mucosal lesions, so the child finds it difficult to swallow heavy and solid food. It's usually caused by Coxsackie virus. So it's called hand, foot, mouth disease. Just like in the term, it involves the hands, the palms, the soles, and also the mouth, including the oral lesions. Usually it is self-limiting. Okay. Dermatophytosis we have talked about previously. We'll just cover that, whatever I've talked about, previously, like regarding the species and all. I've added a slide. So this is trichophyton, microsporum, and epidermophyton. Trichophyton involves all three. Trichophyton involves a hair, nail, and skin. Microsporum do not involve the nail. So wherever there is phyton, you can remember, wherever there is phyton, it involves a nail, and all three involves the skin. So it's the difference is whether it involves a nail or not. Trichophyton involves the nails as well as hair and skin. Epidermophyton, nail and skin. Microsporum, hair and skin. It does not involve the nails. So based on the site also, I've told you it's going to be classified into capitis, that is the scalp. Corporis means body. Cruris means the groin area. Pedis is over the foot, and onychomycosis is the infection of the nails. In tinea corporis, you usually see annular plaque with central clearing. This is classical of the dermatophytosis of the tinea.
With peripheral raised margin, there is intense itching. There is something called tinea incognito. And last year there was this question about tinea incognito. That is, a patient has come. I don't remember whether they've given an image. I don't think they've given an image. But they have mentioned something like that it's a resistant lesion. They have tried steroids on a. The description was regarding tinea, like there is a central clearing with peripheral raised margin initially, but they've tried steroid. So what happens when you use steroid over the fungal infection is that one, there is a flare. Okay, there's going to be flare, and there is going to be, distortion of this morphology. You can no longer see that central clearing with peripheral raised margin. You will see a distorted morphology uh, because of use of topical steroids. For that, you can use azoles or terbinafine. So that is tinea incognito. Incognito means it is, completely changed its appearance. That is tinea incognito. Now let's see a question. So we have seen the viral infections, we have seen the bacterial infections, and also the fungal infections. So a 10-year-old boy presents with intense itching that worsens at night. So there is intense itching that worsens at night. On examination, there is excoriated papules and linear burrows between the fingers, on the wrists and around the waistline. Several family members have similar complaints. What is the most appropriate next step in management? So first, when you see a question, a STEM, you have to identify the keywords. You have to first diagnose it, whether the question is regarding the management, whether the question is regarding the investigations, because that's how the questions are usually framed. They either ask regarding diagnosis, what is the next step in investigation, what is the gold standard investigation, what is the next step in management, what is the definitive management. This is how the questions are framed. So you have to first identify the disease, you have to diagnose it. Only then you can make sure that you're not going wrong. So the itching, intense itching that worsens at night, the distribution, you can see it is between the fingers, wrist, around the waistline. Okay, and there are linear burrows, characteristic and pathognomonic finding you see in scabies. And there is multiple family members which are involved, because usually the scabies can spread usually from the bed. It's called the bed bug and all, right? So it's usually spread usually in the hostel rooms. When you are cohabitating, you can have scabies. So what is the most appropriate next step? So you have diagnosed it as scabies. So what is the treatment of choice in scabies? That is the question. So you can see the options. Prescribe oral antihistamines only. Oral antihistamines can, in a way, help with the itching, but that's not the management of scabies. Add topical hydrocortisone. No, this is scabies. You don't have to use steroid. Prescribe oral ivermectin for the child and symptomatic household members. No, ivermectin is not the drug of choice in scabies. Apply permethrin 5% to the entire body from neck down. This is the treatment of choice in scabies. You have to also treat the family members who are infected. If you are treating a patient from a hostel, you have to treat the cohabitant, whoever is there in the room with that patient, and they have to apply the 5% permethrin cream, sparing the face throughout the body. So you have to spare the face and spread from neck all through the body. You can apply it at night, leave it there and wash it the next morning, and you may have to reapply it a week later. This is the treatment for um, scabies. And permethrin, you also use it for intensive pediculosis. Okay. Treatment of choice is apply permethrin cream. This is a case of scabies caused by Sarcoptes scabi. There is intense pruritus, especially at night, and the characteristic lesions are the burrows that you can see in between the web space or in the finger space. The common sites are called the circle of Hebra, that is your web space of fingers, wrists. There is involvement of the axilla, waist, and genitals. This is called the circle of Hebra. It's usually spares face, and you also don't have to apply permethrin over your face. Permethrin 5%, first line treatment applied from neck to toe, left overnight, wash it the next morning, repeated in 1 week. All household contacts or all hostel contacts should be treated simultaneously to prevent reinfection. Let's see another question. A 6-year-old boy is brought to the clinic with a 3-day history of low-grade fever. So 3-day history of low-grade fever and malaise. His mother reports that this morning he developed a bright red rash on cheeks described as slapped cheek appearance. So they have given the classic description here, that is slapped cheek appearance. Later in the day, a lacy reticular rash appeared on his trunks and limbs. What is the most likely diagnosis? So slapped cheek appearance, no other doubt it is going to be erythema infectiosum. Okay, what is scarlet fever? Scarlet fever is group A streptococca causing sandpaper rash. What is measles? Measles are usually starting from behind the ear, spreading down. Okay, and there is fever. So that is measles. The classic finding is scopic spots inside the buccal mucosa. Roseola infantum, again a rash and a fever with rash, but here classically the fever subsides first and then there is rash, that is roseola infantum. So here this is erythema infectiosum, slap cheek appearance caused by parvovirus B19. You have to know certain things caused by parvovirus B19. Parvovirus B19, just like here, can cause erythema infectiosum, slap cheek appearance in children. It can cause aplastic crisis in sickle cell anemia and hemolytic anemias. It can cause arthralgias in adults. Okay, it can cause pure red cell aplasia. So these are some kind of thing that can be caused by parvovirus B19. It can also cause hydrops fetalis when it infects a pregnant lady, and the child can have hydrops fetalis. Okay, so those are the things. Remember, it can cause aplastic crisis. That is like a repeated question. In sickle cell anemia, which is an infection that is causing aplastic crisis in the patient, it's parvovirus B19. So there is slap cheek appearance common in children aged 5 to 15 years, usually self-limited. Now, since you can get confused between different terminology like erythema marginatum is there, erythema migrans, erythema nodosum, erythema multiforme, erythema, so many erythemas you get. So just now you have learned about erythema infectiosum. So you have to know how to differentiate and what is the catch in all those terms. So tinea corporis, it's ringworm lesions with central clearing, peripheral slightly raised borders, often pruritic. Erythema marginatum, it's non-pruritic, occurs with rheumatic fever. So in rheumatic fever, the John's criteria, one of the criteria is going to be erythema marginatum. You don't get confused. Sometimes they can give in the option erythema nodosum. It's not erythema nodosum, it's erythema marginatum with rheumatic fever. John's criteria, like J for joint, that is arthritis. O for, you can remember heart, that is pancreatitis. N for nodules, subcutaneous nodules. E for erythema marginatum, and S for Sydenham's chorea. Then what is erythema migrans? That is bullseye appearance. With central erythema necrosis, it expands rather than it migrates. So it's actually a misnomer. It's not migrants, it's actually expanding. So that is erythema migrans. Erythema migrans you can get with Borrelia burgdorferi, which is called Lyme disease. Erythema multiforme is usually it's a maculopapular rash on the palms and feet. It's often pruritic, blanches very slowly. It can be seen with mycoplasma or even HSV. The mycoplasma, you have so many things, associations. It's an atypical pneumonia causing organisms. It can have cold agglutination, cold AIHA. It can have erythema multiforme. It can have bullous meningitis. Okay, so many things associated with mycoplasma. It's a type of atypical pneumonia. Then erythema nodosum, that is erythematous macules usually on the shin. That is distribution over the shin. With no central clearing, it's often painful. You can see it with sarcoidosis. Okay, you can see it with inflammatory bowel diseases. So it has many associations. So that is called erythema nodosum. Again, over the shin, you have another lesion called pyoderma gangrenosum, which is again associated with It can be associated with inflammatory bowel disease, but that is like a just like in the term pyoderma, there is like a pus, there is like a an ulceration. It's not actually just a lesion, not just an erythematous lesion. Okay, so erythema marginatum with rheumatic fever, migraines with Lyme disease, multiform with mycoplasma, and nodosum with sarcoidosis or IBD. So those are the different um, erythemas. Also remember pyoderma gangrenosum, that is again distributed over the shin. So I've added image of this erythema nodosum and multiform and all. So here, can you identify this picture? The first one. So here it is distributed over the shin. You can see that there is erythematous lesions over the shin. Okay, that is called erythema nodosum, may be associated with sarcoidosis. So the clinical stem may give a patient with pulmonary symptoms, X-ray showing mediastinal widening with mediastinal lymph nodes. Serum calcium may be elevated, serum AC is elevated, because that is one classical finding that you see in sarcoidosis. So these are the things. And the lesion associated with erythema nodosum over the shin. Next is this target lesion or bullseye appearance of erythema multiforme. Okay, with this a central blister is here. Here there is marked. This is a central blister with edematous ring, and again a very highly erythematous border. So how it is different from erythema migrans? In erythema migrans, again there is 3 zones, but the central zone is erythematous, the peripheral zone is again erythematous, but in between that you have a clearing. That is the difference that it has from erythema multiforme. Erythema multiforme is usually completely erythematous with a central blistering or necrosis. In erythema migrans, there is a central erythematous zone, a peripheral slightly erythematous zone, and with the in between area will be cleared. Erythema marginatum, just like we discussed, it is seen with rheumatic fever. Again, a little bit on erythema nodosum. It's a panniculitis. Panniculitis is an infection of the subcutaneous tissue. It's panniculitis. 60% case it's idiopathic. But sometimes it has other associations which are like drug association, like sulfur drugs, iodides, penicillins, oral contraceptive use, sarcoidosis, one characteristic feature which I've told. Sarcoidosis can come with erythema nodosum. Ulcerative colitis or Crohn's disease, which is an inflammatory bowel disease. Then other infections like TB, leprosy, histoplasmosis, chronic infections. Okay. There is another thing which is called erythema contusiformis. It refers to bruise-like appearance of lesions in late stage of erythema nodosum. Again, it's erythema nodosum. In the later stage, it's called contusiformis. So that was regarding the confusing terms. Let's see another question. A 40-year-old woman with a history of ulcerative colitis. So there is IBD. IBD have certain skin manifestations. One I've told you is erythema nodosum. But I have also given you a clue before that it can have another lesion. Let's see what it is. Rapidly enlarging, painful ulcer on lower leg, usually over the shin. The lesion started as small pustule, progressed to a deep ulcer with violaceous undermined borders. These are the classic description of this condition. No history of trauma. What is the most likely diagnosis? So I told you IBD can be associated with erythema nodosum. It can also be associated with another ulcerative condition. Again over the shin, it's called pyoderma gangrenosum. Okay, not ecthyma gangrenosum. It's a different terminology. It's a different thing. Okay, necrotizing fasciitis, it's it's a microbial infection of the subcutaneous tissue and the deeper. Cutaneous anthrax, again a cutaneous manifestation of anthrax, bacillus anthracis. So this is pyoderma gangrenosum, violaceous border, painful ulcer over the shin in a patient of IBD. Think of pyoderma gangrenosum. So this is pyoderma gangrenosum. It's rare, it's non-infectious, and it's a neutrophilic dermatosis. It's often associated with IBD. Also, there are some other associations like rheumatoid arthritis, hematological malignancies, mainly characterized by painful ulcers. with violaceous abdominal borders, often triggered by minor trauma, that is called pathology. Now, this pathology test you also do in another disease. Can you remember that? That is Behçet's disease. Behçet's disease is a triad of oral ulcers, genital ulcers, and eye lesions. You can have uveitis, conjunctivitis, and all. That's called Behçet's disease. It's a type of vasculitis, right? And that can have pathology test positive. That means if you are trying to draw blood from a patient of Behçet's, after you take the blood, there is a minor trauma there. There you can have lesions. That is called pathology test positive. Okay. Again, in pyoderma gangrenosum, also you can see that. Management, you give systemic steroids or immunosuppressants and not antibiotics because it's non-infectious. Okay, let's see the other things which we have put in the question, that is ecthyma gangrenosum, necrotizing fasciitis, and cutaneous anthrax. How it is different and how do you rule out those conditions? So ecthyma gangrenosum is caused by Pseudomonas. Okay, it's infective. So your pyoderma gangrenosum is non-infective, associated with IBD and rheumatoid arthritis. Ecthyma is, on the other hand, infective, caused by Pseudomonas. Usually in immunocompromised patients, like neutropenic patients, Burns patients, because Burns patients, one of the most common culprit that can cause infection over the burn scar and burn area is Pseudomonas, right? It starts as painless red macule, then a vesicle, then necrotic ulcer with black scar. Okay, just remember that it's going to be infective, caused by Pseudomonas in burns or neutropenic patients. Necrotizing fasciitis, it is a rapidly spreading soft tissue infection, often polymicrobial by gram-negative anaerobic organisms. And the characteristic initial finding is severe pain out of proportion to examination. So initially you may not see the actual necrosis over the skin. It's just spreading. So you have a deeper infection first, and then there you have pain, which is out of proportion to the examination findings. There can be swelling, crepitus, skin discoloration, and systemic toxicity because again, it's polymicrobial, it spreads very, very fast. So mainly you have to treat the patient by debriding, giving higher end antibiotics intravenously. And you have to prevent that spread of tissue infection because once it progresses, the patient can go in for shock and toxemia, and the patient can even die. So emergency surgical debridement along with IV antibiotics is the treatment of choice. Cutaneous anthrax is again infective, caused by Bacillus anthracis, and you usually have a painful papule, then a vesicle, then again a scar, okay, with surrounding edema. And there is usually exposure history with animal products or bioterrorism exposure because these are called the wool sorters disease, right? Wool sorters, which can cause pulmonary anthrax, and hide potters, which can cause cutaneous anthrax. So since we have discussed about erythema nodosum, which is over the shin, we've discussed about pyoderma gangrenosum, again over the shin. There is another condition, again over the shin in diabetic patients. It's called necrobiosis lipoidica. So erythema nodosum was an erythematous lesion over the shin. Pyoderma gangrenosum was an ulcerative lesion over the shin. Now this is yellow-brown atrophic plaque on the shin. Like you can see here, these are atrophic plaque on the shin, which is called necrobiosis lipoidica. It's a granulomatous chronic skin disorder usually seen in diabetics. Okay, just know the term. Because again, it's distributed over the shin, you have to differentiate from erythema nodosum and pyoderma gangrenosum. So since we've discussed about ecthyma gangrenosum, just remember there is another term, ecthyma contagiosum. Ecthyma contagiosum, the causative agent is parapox virus. And it's a self-limited condition. Just know the term, okay? It's a viral infection. Okay, a few more words on photosensitivity. So photosensitivity means it's an exaggerated skin response to sunlight, primarily the UVA, UVB radiations, which can lead to either rash, there can be erythema, or even burns. Okay, so usually the clinical clue is rash over the sun-exposed area, especially the face, neck, the V of chest, forearms, especially the exposed areas. and the sparing areas. And in chronic cases, you may have hyperpigmentation or even lichenification. Lichenification means there is thickening of that skin. Now, photo sensitivity can be phototoxicity or photoallergic reactions. So, phototoxicity is the most commoner type. It's non-immune mediated and it's a direct tissue injury after sun exposure. However, photoallergic, it's a delayed type for hypersensitivity. So, it's immune mediated and it's delayed. So, it's 24 to 72 hours post exposure. So, clinically, in phototoxic reaction, you usually have sunburn like rash, erythemas and blistering. Okay, so it's slightly milder. Photoallergic reaction, on the other hand, it's eczematous. There is itchy rash which resembles contact dermatitis, because contact dermatitis again is type for hypersensitivity reaction, which is an immune mediated condition. And there are certain drugs which can cause photosensitivity, some cause phototoxicity, some cause photoallergic reactions. Some of the drugs you just have to know the names. You don't have to like classify that into two and learn. You have to know that doxycycline can cause phototoxicity, or amiodarone, which can cause many other things like pulmonary fibrosis. It can cause hepatitis. It can cause corneal deposits. Okay, it can cause skin lesions, especially over the face and all. That's a photosensitivity caused by amiodarone. Then thiazides, psoralens, fluoroquinolones. Then photoallergic reaction may be by sunscreen, especially over sensitive skins, fragrances, NSAIDs, and phenothiazines. Mainly remember doxycycline, amiodarone, and your sunscreens and all. There are some important conditions or diseases which are also associated with photosensitivity. One being SLE. SLE, in the criteria itself, you know, the diagnostic criteria, you have photosensitivity, right? Then porphyrias, especially the porphyria cutanea tarda, can have photosensitive rashes. Dermatomyositis, okay, and again an autoimmune condition. Polymorphous light eruptions, all this can have photosensitivity. How do you prevent and how do you manage? You can use sun protection by clothing, sunscreen, stop the offending drug like amiodarone, doxycycline we have mentioned, topical steroids for the allergic forms of the condition, and antihistamines for the symptom relief. Okay, so that was photosensitivity. Let's come to bites. There are insect bites, animal bites, human bites, and poisonous snake bite, spider, scorpion bite, and all. And the treatment depends on how it manifests, right? So insect bite can be mosquito, bees, as we usually have an IBR, that is insect bite reaction, especially in children. Animal bites, it can be dogs, cats, rodents. You have to give anti-rabies vaccines, especially if it's a wild organism. It's a category 3 or category 2 wound. In category 3, you also have to give immunoglobulin, right? Human bites, it's often more infectious, and the organism which can cause infection in dog bite as well as human bite, it's Pasteurella maltosida. There are many other organisms, usually Pasteurella maltosida, and the treatment is amoxicillin. Snake, spider, scorpion, there is envenomation risk. You give anti-snake venom, okay, anti-spider venom, and you have to manage the patient based on this the species also, because there are 3 different species: the Hydrapidae, Elapidae, and Viperidae. Viperidae is hematotoxic, and the Elapidae family is the sea snakes are myotoxic. It can cause renal failure. The Viperidae can cause hematotoxic and also local reactions, and the other one is neurotoxic. And there are local reactions is more with the viper family. There is pain, redness, swelling, puncture marks, and bleeding. And there are systemic findings also, like fever, allergic reaction, anaphylaxis, especially incense stings, anaphylaxis, and scorpion bite. If the patient presents with anaphylaxis, you manage the anaphylaxis with IM epinephrine 1,000 0.5 ml. If they present with other symptoms like there is priapism and all, you have to give Prazosin. That is a treatment of choice. Okay, in snake bite, you can have neurotoxicity and shock and severe bites. So again, complications of bites from scorpion or snake or others can be local infections. Again, we told the common organism is Pasteurella multocida. It can be other organisms which usually cause skin infections like strep and staph. It can lead to cellulitis. If it's a dog bite or a wild animal bite, it can lead to rabies, which is a fatal infection. You know, the fatality is 100%. So you vaccinate the person if it's category 2 or category 3 along with a vaccination. For category 3 wounds where there is visible oozing of blood, or if it's a wild animal bite, you always give immunoglobulin. Then with any other bite, any other wound, you can get tetanus, so you give injection TT also. Again, 0.5 ml IM. Again, if for tetanus prophylaxis, what is more important is whether the patient has already received a full tetanus prophylaxis. Like you have in the national immunization schedule, you give it at 10 years, 15 years. So if that has been completed, then you can give one shot booster. Otherwise, if there is no history of immunization available or the patient hasn't received any vaccination before, you have to give a full course of tetanus starting from that day. Then there can be allergic reactions, especially with insect bite. There can be insect bite reactions and envenomation effects with especially snakes, spiders, scorpion. Scorpion bite and all, you can have anaphylaxis. Snake bite, just like we told. There are three main types: Elapidae, Viperidae, and Hydratidae. Hydratidae as the sea snakes. Elapidae causes neurotoxic. They are neurotoxic. Viperidae are hematotoxic, and Hydratidae are myotoxic. So it can cause renal failure with myoglobinuria. Viperidae also has severe local reactions, okay, at the site of bite. So how do you manage a patient? Now this is different for the dog bite, this is different for the scorpion bite, this is different for the snake bite. So we'll take a scenario and see. If it's a dog bite, what do you do? So if it's a dog bite, you categorize the wound. In dog bite, there are three categories of wound. Category 1 being there is maybe a dog has licked over intact skin. There is no visible wound, no scratching, and no oozing of blood. Okay, maybe just contact with the organism. In that, the you have to only wash the wound thoroughly with water. It's open water for at least 10 to 15 minutes. Okay, on running tap water. That's how you wash it. So that is for category 1. What is category 2 wound? So category 1, you actually need you not give vaccination, you only wash the wound. Category 2 means there is some some aberration of the skin already, and the animal has licked over that aberrated skin, or there is a scratch but no oozing of blood. If there is oozing of blood, it becomes category 3. So for category 2 wounds, you give vaccination. The vaccination schedule is usually intradermal or intramuscular. There are two kinds of regimen. If it's intradermal, you give on both the deltoids on 0, 3, 7, 20 on 4 different days, right? And you have category 3, which is wild animal bite or a dog bite, which has led to oozing of blood. Okay, that is category 3. Along with vaccination, you give this IVIG, immunoglobulin, which is the human immunoglobulin or the equine immunoglobulin. So these are the things. You give injection TT, you stabilize the patient, you wash the wound thoroughly with tap water. That applies to all the categories. Along with that, for category 2, you give vaccination. For category 3, along with vaccination, you give immunoglobulin. So that is for dog bite. What about, let's say, scorpion bite? That's another scenario that we usually get. So scorpion bite, the scenario can be two things. It can either be the patient presenting with priapism, there you give prazosin, or the patient presents in anaphylaxis, then you manage the anaphylaxis by giving IV IM adrenaline 1 in 1000 0.5 ml. Okay. Now snake bite. Snake bite, you have uh, three different species, right? The Elapidae, Viperidae, and Hydratidae. You usually give the anti-snake venom, and you stabilize the patient, and there is no need of uh, creating a wound over that bite. Sometimes in ancient times we used to create a wound and incise and try to take the venom out. That doesn't work. You don't have to manipulate the wound. You have to maximally stabilize the patient, immobilize that area. You can maybe tie a loose tourniquet and actually take them to hospital, and then uh, make the medical management, make it available easily and earlier to the patient, rather than trying so many other unscientific, unproven things. So generally there is stabilization. You have to uh, do wound care, control the bleeding, consider antibiotics, especially in case of any kind of bite. You give amoxiclav, or alternative, with pencil allergy, you can give doxycycline plus metronidazole. Tetanus prophylaxis is usually given if they have already been vaccinated. You give a booster dose. If there is no history of vaccination prior, you have to give a full course of tetanus prophylaxis. Rabies prophylaxis, it's the immunoglobulin along with the vaccine for category 3 wound. For category 2, you only give the vaccine. Anti-venom if snake bite and there is systemic signs. Insect bite management, you give ice packs, you give antihistamines for the itching, and topical steroids. For anaphylaxis, give IM adrenaline 1000 0.5 ml. The dosage and the strength of adrenaline given in anaphylaxis is itself a question being repeatedly asked. So just remember that. Now let's see a question. A 10-year-old boy presents with fever and a swollen tender lymph node in the axilla. Mother reports that he was scratched by a kitten 2 weeks ago. So just there itself, there is the diagnosis. Being scratched by kitten now with tender lymph node, that is called cat scratch disease. Cat scratch disease, right? The other options are toxoplasmosis, tularemia, sporotrichosis. We'll see why they are not the options. So it's cat scratch disease caused by Bartonella henselae. Typically presents with localized lymphadenopathy 1 to 3 weeks after scratch from a scratch or even bite from a cat. Again, toxoplasmosis has contact history with cat, but the presentation is different. Especially it's dangerous when it is infected in a pregnant lady. The child can be affected with congenital toxoplasmosis. Okay, but here it's a cat scratch disease. It's not as dangerous as toxoplasmosis. Fever may accompany the lymph node swelling. Why the other options are not the case? Tularemia and sporotrichosis are less likely with without specific environmental exposure. Sporotrichosis, usually there is a thorn prick. It's usually inoculated. It's called Rose Gardner's disease, and it's a usually thorn prick. Tularemia is by Francisella tularensis, and it is with contact with rabbits, ticks, or flies. There is ulcer at the site of entry, regional lymphadenopathy, fever, and systemic symptoms. Sporotrichosis caused by Sporothrix shenkai. It's called Rose Gardner's disease, and it's a painless nodular lesions along the lymphatic channels. That is a characteristic after the skin trauma from plants or soil. Toxoplasmosis, present differently. It's more common after exposure to, again, cat feces, not by cat scratches, and it's dangerous in a pregnant lady when the infant fetus can get affected with congenital toxoplasmosis. This is just a flow chart of what to do in chronic pruritus. So in pruritus, if it can be a dermatological course or a non-dermatological course. Okay, in non-dermatological course, one thing you have to always rule out is psychogenic pruritus. So rule out anxiety, depression. So there is, you know, there is a patient scratching themselves, especially in the accessible areas, just like we've mentioned about trichotillomania, where the patient is plucking his or her own hair. Now the patient is scratching his own accessible areas over the skin. There is extensive excoriation because the patient keeps on scratching. It's also called dermatosis artifacta because it's an artifact and the patient itself is causing the harm. That's called psychogenic pruritus. So rule out that. Not that it is the first differential, but you have to keep in, the back of your head that it can be psychogenic. Especially if you see a pattern where the patient is anxious, there is some history of depression, and the patient is constantly scratching over accessible areas. It can also be It can also be due to some other systemic causes like CKD, where there is uremia. You can have constant scratching and pruritus, cholestatic liver disease due to the bile salt, and hematological malignancies you can have. And then neuropathic itch, again post-herpetic. There are some nerve involvement. Sometimes it may subside with gabapentin or dosh. So maybe due to neuropathy, the patient may have constant irritation and itching. Okay, other dermatological causes, um, you can have seborrheic dermatitis or contact dermatitis, or if there is a history of allergy previously, it can be urticaria where there is a characteristic wheal, psoriasis where there is scaling, nummular eczema, especially on the flexors, scabies where there is, a similar history in the family or in the contact of hostel or household. Okay, or if you are not able to recognize, maybe think about bullous pemphigoid, maybe you have to take a skin biopsy. This is just a differential to keep in mind. Now we'll come to the last topic, which is skin neoplasms. Okay, there are pre-malignant conditions and the actual malignancies, which are mainly three, which is basal cell carcinoma, squamous cell carcinoma, and malignant melanoma. We'll see how they are different and what all are important regarding them. Seborrheic keratitis, these are not malignant, these are benign lesions. It has got a stuck-on appearance. See here, it's a stuck-on appearance. It has no malignant potential, and it's exophytic, waxy, brown papule. It can be velvety or greasy plaque with superficial keratin cysts. Okay, that is the classical characteristic description. You just have to know the name. You just have to know whether it's benign or malignant, because sometimes they can ask what are the pre-malignant lesions of the skin or what are the malignant lesions of the skin. So seborrheic keratitis is purely benign. This is lesser Trillat sign. Where do you see lesser Trillat sign? In some internal malignancy like gastric carcinoma, you can have cutaneous manifestations, which is called lesser Trillat sign. Okay, extensive lesions here. You can see something like a hyperpigmented waxy like lesions over the back. Okay, this is seborrheic keratitis over the back, which is extensive in internal malignancy. Another thing is actinic keratosis caused by sun exposure. There are areas of erythema and scaling. Here, there is a slight risk of turning into malignancy, that is 5 to 10% risk of squamous cell carcinoma. The treatment of choice is cryosurgery. You can try topical 5-fluorouracil or topical imiquimod. Now we'll come to the major three: squamous cell, basal cell, and melanoma. Melanoma, from the name, it's of the melanocyte. The melanocytes are present on the stratum basale. So it's a little bit more deeper. Okay, and there is a B, C, D, E, which is a characteristic finding which you see in melanoma. We'll discuss that in a while. And there is squamous cell carcinoma and basal cell carcinoma. The distribution is different, the characteristic appearance is different, and the prognosis is different for all three. So this is how there are the pre-malignant lesions and how they finally go in for the malignancies. So there is hyperkeratosis. Hyperkeratosis means increase in that cell count, right? Hyper means increase. Keratosis means keratocytes are increasing. And finally, they can go for atypia, dysplasia, and finally the malignant potential, and they invade the basement membrane and finally go in for carcinoma, which is a basal cell carcinoma. Or sometimes they can go for some in situ cancers like Bowen disease, which is also considered as the precursor lesion of squamous cell carcinoma, and finally they can go for a full-blown squamous cell carcinoma. Under histopathology, you always see keratin pearls. That is a characteristic finding that you see in a histopathology slide of squamous cell carcinoma. Okay, now we'll discuss all this. Basal cell carcinoma, that's the most common malignant skin cancer. It is slowly growing, it's locally destructive, so it's called a rodent ulcer. It has a low malignant potential, and that means the distance spread is usually less. It is usually a nodular ulcerative lesion, or sometimes there is a pearly white, translucent, dome-shaped nodule or papule. And it can ulcerate, bleed, or even crust. There can be overlying telangiectasia. Here you can see in this lesion, there is a pearly lesion over the ala of the nose. There is overlying telangiectasia. If you carefully watch here, you can see the telangiectasia. Okay, and the site of lesion is characteristic. If you draw a line from the angle of mouth to the ear lobule, above that line, that is usually the site of basal cell carcinoma. Under histopathology, you can see nests of basaloid cell, often with peripheral palissading. That is the description. And the treatment is most micrographic surgery. Okay, microscopically, you're trying to remove the lesion with margin. You're trying to remove all the cancer cells. Okay, this is Mohs surgery. There is a visible lesion on the skin, and there will be some depth of that lesion also, which you can't actually visibly see with your naked eye. What you do is you remove layer by layer, very thin layers. Okay, and then under the microscope you visualize it, you see if there is any more thing, and then you do it layer by layer. So you don't have to, you don't have to take it like this deep. That will leave a very big scar, because basal cell carcinoma, there's low malignant potential, it's slowly growing, and it is over the face. So you're trying to preserve that normal morphology as much as possible, and you're trying to remove that layer by layer. Okay, trying to remove only the cancerous areas. Next is squamous cell carcinoma, and second most common skin malignancy. Again, there can be a predisposition to sun exposure. With sun exposure, there can be actinic keratosis that can lead to even squamous cell carcinoma. Keratoacanthoma is a low-grade squamous cell carcinoma, and Bowen's disease, just like we have seen, it's a squamous cell carcinoma in situ, generally considered as a precursor lesion in case of squamous cell carcinoma. So it's over the burn scar. If you develop squamous cell carcinoma later on, it's called Marjolin ulcer. Usually it's erythematous ulcerated papule or nodule. In basal cell, the description was more like a pearly over the face, slowly growing. Here it is erythematous, and it's ulcerated papule or nodule. And histopathology shows keratin pearls. These are the keratin pearls. This one you see. There are so many keratin pearls here. This is what you see in squamous cell carcinoma. Now, malignant melanoma, according to the distribution, it can be classified into lenticulomaligna, superficial spreading melanoma, nodular melanoma, etc. or acral lentiginous melanoma. Acral lentiginous means on the periphery. Lenticulomaligna is usually over the face. Superficial spreading and then nodular. Now there is ABCDE for malignant melanoma. A means there is asymmetry of the lesion, and B is for the border, so there is an irregular border. Okay, so if you have a normal border, maybe mostly it's benign. If you have an irregular border, think of malignant. C is for color, which means it's the mix of hyperpigmented areas. So there is no uniform color. D is for diameter. So it's usually larger in diameter. And E is for evolving. The lesion keeps on evolving. There is change in size, change in color, change in, the border. That is called evolving. So asymmetry, irregular border, different colors, diameter, and evolving lesion. And it can metastasize to the lung, to the liver, to brain, and fat. And the most important prognostic factor, this is a previous year question, most important prognostic factor in case of malignant melanoma. Sometimes they give malignant melanoma, sometimes they give a description of malignant melanoma, like there is a hyperpigmented or an irregular border lesion over the skin, which is hyperpigmented. It is evolving. Okay, so you're pointing towards malignant melanoma. They ask what is the most important prognostic indicator. It's breast thickness or depth of invasion in millimeters. Ulceration again is a poor prognostic sign. Now this I've added just so you know what are the different types of biopsies that you can do in dermatology. There is something called a shave biopsy. There is something called a punch biopsy wherein you are taking the epidermis along with the dermis. And if you're taking the whole lesion, if it's a bigger lesion, you can do an incisional biopsy. If it's a smaller lesion, you can take the whole thing out. That's called excisional biopsy. So these are different kinds of biopsy. There's also wedge biopsy in case of an ulcerative lesion. You're taking the edge of that ulcer along with some normal area. That's called wedge biopsy. Okay, just so you know the terms. So that's all. Thank you. We have completed dermatology. I've included almost all the previous questions of dermatology. We'll try to cover the rest of the topics in the coming days. I'll give you an overview of how we are going to do the topics and how we are going to go about it. So that's all. Thank you so much.